welcome back to my channel. Today we will be talking about pericarditis and its types. Before we dive into pericarditis, let's first talk about pericardium. Pericardium is the outer layer of the heart that protects the heart, provides a gliding motion for the heart, prevents kinking of the vessels, and prevents overstretching of the heart. If we take a cross section of the pericardium, we will find that it has the following layers. The first layer is the myocardium. The second layer is the visceral layer of the serous pericardium. The third layer is the pericardial cavity. The fourth layer is the parietal layer of the serous pericardium. And the fifth layer is the fibrous layer of the serous pericardium. The most common layers involved in pericarditis are visceral layer of the serous pericardium, pericardial cavity, and parietal layer of the serous pericardium. Pericardial effusion accumulates in the pericardial cavity. So what is pericarditis and what are the types of pericarditis? Pericarditis is the inflammation of the visceral layer, the parietal layer, and the pericardial cavity. So these three layers are commonly involved in pericarditis. Now what is pericardial effusion? The pathophysiology behind the accumulation of pericardial effusion is that whenever there is inflammation of any of these layers, cytokines are going to be released. The cytokines are going to make the blood vessels permeable. This will cause fluid to ooze out of the blood vessels, which can either be soaked up by the fibrous layer of the serous pericardium or it can accumulate as effusion in the pericardial cavity. This will lead to increased fluid in the pericardial cavity, and this is called pericardial effusion. This is a complication of pericarditis. This occurs mostly in pericarditis, but sometimes it might be absent. Pericarditis has two types: constrictive pericarditis and pericardial tamponade. Constrictive pericarditis happens when acute pericarditis becomes chronic or recurrent, which means if it turns more than 3 months, the pericardium turns into a fibrous inelastic shell. When this turns into a fibrous inelastic shell, the heart will not be able to stretch, and this pericardium will exert pressure onto the heart. This will lead to decreased cardiac output and in turn decreased blood flow to the rest of the body. And it can lead to a myriad of different kinds of complications. Now, what is pericardial tamponade? Pericardial tamponade happens when there is so much effusion that the pericardium cannot stretch anymore. The effusion can be blood or fluid. So, when the volume increases so much, the fluid starts squeezing onto the heart. This will decrease the venous return to the heart and decrease cardiac output. The decreased cardiac output is due to decreased ventricular filling. This develops rapidly. Now let's study pericardial diseases from First Aid Step 2 CK book. Pericardial diseases can be acute or chronic. In acute setting, it is less than 3 months, and in chronic setting, it is more than 3 months. Pericardial diseases are usually inflammation of the visceral pericardium, parietal pericardium, and pericardial cavity. It consists of pericarditis, constrictive pericarditis, and pericardial tamponade. They all may lead to a complication called pericardial effusion. First, let's talk about pericarditis. Pericarditis is the inflammation of pericardial sac. It can compromise the cardiac output via tamponade, that is extravasation of large amounts of fluid secondary to pericarditis, or constrictive pericarditis. Now, let's discuss some of the causes of pericarditis. The causes of pericarditis can be remembered with the mnemonic cardiac rinse. The most common cause of pericarditis is infections. The infections usually involve viral infection, which includes Coxsackie B virus and SARS-CoV-2 virus. SARS-CoV-2 virus is the same virus that has caused COVID-19, and it can be detected via PCR test. They will lead to symptoms such as rhinorrhea, sore throat, congestion, etc. Other than that, these infections can be caused by bacteria as well. The bacterial infection will include pathogens such as Staphylococcus aureus, Streptococcus pneumoniae, Mycobacterium tuberculosis, and they usually happen after recurrent thoracic procedures. Anything that will require for you to open the thoracic cavity and perform a surgery can lead to opportunistic infections. The pathogens involved in those infections can be Staphylococcus aureus, Streptococcus pneumoniae, and Mycobacterium tuberculosis. Some other causes can be collagen vascular diseases, which is usually autoimmune, and it includes SLE, scleroderma, rheumatoid arthritis, etc. In these, autoantibodies will form like rheumatoid factor and ANA, and they will cause inflammation, which will result in effusions. Aortic dissection can also result in pericarditis. Let's suppose this is the aorta. In aortic dissection, blood will start to accumulate between the innermost layer and the middle layer of the aorta. This blood can trickle down into the pericardium and cause pericardial effusion and pericarditis. That is why aortic dissection is one of the causes of pericarditis. Radiation can also result in pericarditis. The reason behind that is that if you're having chemotherapy for any reason, for any carcinoma, that will destroy your pericardial tissue, and that destruction will result in inflammation. And inflammation is the reason behind pericarditis. Drugs can also result in inflammation. Acute renal infections like acute kidney injury, which can also lead to chronic kidney disease, can eventually lead to end-stage renal disease, and then the person is on hemodialysis. This will deplete the person's ability to excrete urea and in return cause uremia. If uremia goes to the heart, it will deposit in the pericardium and that will result in inflammation. Another cause can be rheumatic fever. Injury, specifically penetrating injury, can also result in pericarditis. Some neoplasms can also result in pericarditis. Some of them are lung carcinoma, non-Hodgkin lymphoma, leukemia, renal cell carcinoma, breast cancer, etc. And they can metastasize to cause pericarditis. Dressler syndrome. Now, what is Dressler syndrome? Now, whenever there is a cardiac injury, for example, an MI, that will result in no oxygen to the cardiac tissues and tissue destruction will happen. That will result in inflammation and pericarditis. If this pericarditis occurs for 1 to 3 days post MI, this is called a post-infarction pericarditis, and that is this cause. But if this happens 14 days to months after MI, then we will call it Dressler syndrome. In Dressler syndrome, not only inflammation but fibrosis also occurs. The inflammatory cells present some of the myocardial proteins to the lymphocytes, which forms memory cells against them. And these memory cells make antibodies against these proteins. Some of these proteins look like pericardial proteins and they will result in inflammations 14 days to months after MI. And that is called Dressler syndrome. Lastly, surgery can also result in pericarditis and we will call it post-pericardiotomy syndrome. Now let's talk about the history and presentation of a person that has pericarditis. The pain of pericarditis is very specific pain. The chest pain will be pleuritic in nature, which means that it will change with respiratory cycle. With inspiration, which squeezes the heart, the pain will increase. So whenever a person takes in air, his pain will increase, and this is called pleuritic chest pain. The pain will be sharp in nature and it will be radiated to the trapezius muscle. The location of the pain will be substernal. This is a very specific pain, which is the pain of the pleura. Other than this chest pain, dyspnea can happen, cough can happen, and fever can happen as well. Chest pain tends to worsen in the supine position. So, the pain is not only pleuritic and sharp and radiating to the trapezius muscle located in the substernal region, it is also positional pain. Why does it increase in the supine position? Because the abdominal contents will push up on the diaphragm and that will result in the inflamed pericardium to become closer to the diaphragm, and that will increase the pain of the patient. Usually when the patient comes to you, you will see that the patient is sitting up and he is bending forward, because when he sits up, the diaphragm will drop down and the heart will move a little anteriorly, which means the pressure will alleviate. You might also find the patient standing up. So these are some of the maneuvers that will help the patient in alleviating his pain, and that's how you will find the patient most of the times. When you examine the patient, what will you find? You will find a pericardial friction rub, and you will hear this most commonly during atrial systole, ventricular systole, ventricular diastole, which makes it triphasic, and this will be a scratchy sound. So there will be pericardial friction rub, which is going to be triphasic, which is going to be in atrial systole, ventricular systole, and ventricular diastole. The JVP will be elevated. The reason behind the JVP being elevated is because the heart cannot accept more blood from the superior and inferior vena cava, and because of that there will be back pressure of the blood onto the jugular vein, and that you can see as jugular venous distension. There may also be tachycardia, because that will be the heart's compensatory mechanism to push blood forward into the rest of the body. And the sounds of S1 and S2 might be muffled, dampened, or distant. And the reason behind that is that, let's suppose this is your heart and this is the pericardium and there is pericardial effusion here, and you're putting the stethoscope here. So the heart sounds not only have to cross the heart muscles, then the effusion, then the last layer of the pericardium, then the skin, and then finally it reaches your stethoscope. That will make the heart sounds a little muffled. And there will also be pulsus paradoxus, which means systolic blood pressure decrease of more than 10 millimeter hydrogyrum on inspiration. So basically what happens is normally that when you expire, this is your normal systole. And when you inspire, your systolic blood pressure decreases just a little bit. This is going to be your systolic blood pressure during expiration and then during inspiration. But when this distance becomes like this is the expiration and this is the inspiration, and it becomes more than 10 mmHg, this is called pulsus paradoxus. And it happens specifically in pericardial tamponade. And there's also going to be the Kussmaul sign, and Kussmaul sign usually you'll find with constrictive pericarditis. So this pulsus paradoxus is specific to pericardial tamponade, and this Kussmaul sign is specific to constrictive pericarditis. Lastly, you will find a dullness to percussion at the lung base. So the reason behind that is that the inflamed heart compresses the lungs. Let's suppose this is the heart and this has become super inflamed, and on the left side we have the lung behind the heart. What this is going to do is that the inflamed heart is going to compress the left lung base, and air cannot enter this part of the lung, and this will act like consolidation. When you percuss it, you will hear dullness to percussion at the left lung base. Other than that, let's suppose this is your lung and this is your bronchi and this is your other lung and this is your bronchi, and this is, it's branching, and then lastly it gives blood to the vesicles and everything, right? So when you put your stethoscope on the lungs, you're supposed to hear vesicular breathing sounds, which is the normal breathing sounds. But since over here there is the sort of consolidation because of the pressure of the heart on the lung, you will be hearing bronchial breathing sounds. So the sound will not be coming from here. Whatever you will hear will be coming from here, the bronchi. So this is called bronchial breath sounds, and that is what you will be hearing in a patient with pericarditis. And other than that, there will also be tactile fremitus at the left lung base. So what are some of the ECG findings? In ECG, you will find that there will be ST segment elevation, which is a common sign of STEMI. But the way you can differentiate the ST segment elevation of pericarditis from that of STEMI is that there will be a concavity. This ST segment elevation will be saddle shaped, which I'll show you in just a bit. And a few other things will be PR segment depression followed by T wave inversion. So let's look at those. So let's suppose this is the ECG and we're looking at lead 2 and we want to see the ST segment elevation. So diffuse ST segment elevation means that the ST segment elevation you will find in almost all leads. The way you can differentiate it from the ST segment elevation of MI is by looking at this, and you will see that there is a concavity. And if you look at the ST segment elevation MI, you will find that there is elevation, but there is a convexity. And another thing is that it will not be usually diffused, it will be present in few leads. Another thing that you will find is that the PR segment is depressed, and this will usually happen in the inferior lead. So if you look here, the PR segment is depressed. It usually goes something like this, right? But over here the PR segment is depressed. And lastly, if there's a large effusion, for example in cardiac tamponade, the QRS voltage will be decreased because the impulse has to go through the fluid to reach the lead. Usually the QRS complex should be like this, but in these cases it will be something like this, which is not normal. If we would do a chest x-ray, we would find cardiomegaly, and that will indicate that there might be pericardial effusion, but this is not a very specific sign, and this can happen in so many other causes as well. We will not concentrate on chest x-ray that much, and we can also do some other blood tests that might point us to what has caused the pericarditis, and some of those tests can be full blood count, ESR, UNEs, cardiac enzymes like troponin, and viral serology, autoantibodies, fungal precipitants, and TFTs, but they will all be to find the cause of the insult and not so much as to the diagnosis of pericarditis. The most important thing that we can do is echocardiogram, and what it will show to us is that there will be pericardial thickening or effusion. We can just see the effusion. If we feel like the effusion might be purulent, for example, if we find that the patient is feverish or the patient has a septic appearance, or it is a post-thoracic surgery or malignancy, we suspect that the effusion might be purulent. We might also do pericardiocentesis, which is basically tapping of the fluid, and we can send it for culture and sensitivity, gram staining, acid-fast bacilli, cytology, etc. And we can find the cause of the insult. After we have established that this patient has pericarditis, how can we treat this patient? So I will teach you from here. I have made it a little more organized. First of all, we will give an increased dose of NSAID, non-steroidal anti-inflammatory drugs, right? They will control the inflammation, and inflammation is the main insult, and we want to control the inflammation. So for that, we can give ibuprofen, indomethacin, ASA, which is aspirin, and this is the preferred one. So what it would do is that it will inhibit the COX, and that will decrease or inhibit the inflammatory mediators or the cytokines, and we're supposed to give this for 7 to 10 days. Usually we also combine it with colchicine. The neutrophils that are in the vicinity causing inflammation have microtubules. The microtubules are basically for migration and phagocytosis. Colchicine will inhibit these microtubules of the neutrophils, and that will inhibit the migration and phagocytosis by these neutrophils, and finally it will reduce the recurrence. So this we will give for stopping the inflammation, and this we will give for stopping the recurrence, and they are usually given in a combination. We can also give steroids, but steroids we have to use with a lot of caution, and we have to try to avoid them as much as we can because it can cause an increase in the rate of recurrence. But this might prove helpful in patients with TB, and it may reduce recurrence in patients with TB. We're supposed to give steroids in those cases where we cannot give aspirin. For example, in uremia, NSAIDs is contraindicated, and if someone has a peptic ulcer disease, we cannot give ASA, so we give steroids instead. And also in patients with autoimmune diseases, we might want to give steroids because steroids will depress the immune system, and in autoimmune diseases your own immune system has gone crazy, so we want to give steroids in autoimmune diseases as well. So lastly, we have an invasive treatment, and we usually do the invasive treatments in cases where the other treatments fail. If there's purulent pericarditis, we will drain the pericarditis and we will give them systemic antibiotics, but drainage is very important in these cases. Other than that, if there is so much effusion that we cannot treat it with other drugs and there's recurrence again and again, for example in malignancies, we can do pericardiocentesis and then drainage. Now that we have discussed pericarditis, I want to lightly touch upon the criteria for pericarditis. So the criteria for pericarditis includes chest pain specific for pericarditis, which we've talked about already, which is pleuritic, substernal, positional, radiating to the trapezius, and there's going to be frictional rub, which you can appreciate with your stethoscope, and there's going to be ECG changes like ST segment elevation, which are going to be diffuse, and there's going to be concavity present, PR segment depression, and QRS voltage decrease. On echo, you will find a new effusion and the worsening of previous effusion. So these are some of the things that might conclude that you have a pericarditis at hand and you need to treat it with ASAs or colchicine or maybe steroids or pericardiocentesis or drainage and all of that. And this sums up our discussion of pericarditis for today. In the next video, we will be talking about constrictive pericarditis and pericardial tamponade. If you like this video, then subscribe to my channel and maybe turn on the notification bell. And thank you so much for watching if you made it till the end. And I hope you learned something. And until next time, take care of yourself. Bye.